Hello, my name is Jake Okechukwu Effoduh. I am the Chief Counsel of the Africa-Canada AI and Data Innovation Consortium, popularly called ACADIC. You already know what we do at ACADIC. We have a mission to use AI and big data techniques to help build resilient governance strategies in the Global South. Pretty much we're helping with the use of AI and big data to increase societal preparedness for global future health pandemics and climate disasters. On the perspective-based side of ethics, we have to think contextually, and we always have to ask ourselves, where is our data coming from? Who needs special protection? Does our work cover does it involve children? Are we using an embodied AI system, or is it only software? And because we work in sub-Saharan Africa, there is the data anonymization network rules that we have sort of deployed. I have like an acronym I've created. I call it FRPITA, F-R-P-I-T-A. They cover the 6 key ethical guidelines. The first is fairness, the F, fairness. The R is reliability and safety. The P is privacy and security. The I is inclusiveness. The T is transparency. And the A is accountability. I could just touch a bit on some of these ethical rules. When we talk about fairness, we have to ask ourselves, who is this research for? What are the benefits? Is this research fair on the people? Is this research fair on the planet? Because AI systems have to be designed in ways that they minimize ecological footprints and increase energy efficiency. When we talk about the R, which is on reliability and safety, in healthcare, we have to comply with the cornerstone of ethics, which is do no harm, the do no harm principles. AI system used in healthcare must comply with this principle as well to ensure that harm is prevented when we use AI technologies. But also, we need to think about the duty to warn, to just warn people if the information, the data, if the technology could create some incidental problem. The P is on privacy and security, which obviously is quite resounding in the literature. When we talk about the privacy and security, we're not just talking about the data and the people that we're collecting the data from. We're talking about the data controllers as well, the data processors, ensuring that there's some form of control within the individual to have privacy by design and not by demand, right? Privacy by design, not by demand. And also because our data sets are cross-border, across LMIC countries, we have to think about the data protection laws, which I mentioned earlier. The I is on inclusiveness, which requires that AI system used in healthcare is designed to encourage the widest possible, appropriate, equitable use and access, irrespective of whether, just to ensure that we're protecting people's identity in terms of their protection personally, but also we want to see an inclusive approach to how our system operates. Inclusiveness in terms of people's gender, race, age, sexual orientation, health status, and the rest of that. Inclusiveness not only in terms of the data, actually, but inclusiveness in terms of the people who we're working with. Inclusiveness in terms of people who are even reviewing the work that we're doing, to ensure that we have this represented between providers, between patients, between respondents of our research. The T is on transparency, which is an ethical value that we can't obviously overstate. When we talk about the need to trust the system and trust the data and trust the output of what we're creating, trust is reliant on the need for transparency to ensure that we are facilitating meaningful consultation with the people, giving them the opportunity to debate the data, to debate the technology, how it's been designed and how it's been used, and to ensure that we're able to tailor information to each population and each country that we work with. Of course, there is a trade-off between accuracy and explainability when it comes to AI. And people say AI systems are not completely explainable, but so are so many other technologies and so many other concepts in the world. But we need to ensure that we are providing as much information that can help in understanding how the technology is being used in this region. And the last ethical guideline is on accountability, which for me, from a legal perspective, speaks a lot about responsibility to ensure that we can assure people of what we call the human warranty to ensure that, you know, our regulatory principles are applied upstream and downstream of the algorithm as well, so that there is some form of like human supervision to eliminate errors, you know. I always say, you know, we have to ask ourselves, who do we hold responsible if things go wrong? When can we hold responsible? What are the effective remedies that are available to people? Restitution, you know, what kinds of sanctions as well, where there are some form of defaults. We can ensure human agency by ensuring that the design, the development, the deployment of AI systems for health is mediated by humans. So whatever research system we're using, whatever big data system we're using, we obviously go back academically, go back to like Nicholas Granham's mediation framework on the role of like technological agents versus human agents. So people have said there's so many ways, you know, because AI for health is it has to do with life and death, you know, issues. And so there's so many propositions, and I could list a few. For example, last year, the UN High Commissioner for Human Rights proposed a moratorium on AI systems that are high human risk. So we can, if we feel that they are high risk, you know, we can ensure agency by like a moratorium on some of these high risk systems until and when we're sure, you know, of its usage and how we can mitigate some risk. Another option could be by limiting the use of automated decision-making completely. So if we have control mechanisms like what we call the human-in-the-loop systems, rules for algorithmic developers to ensure that they can adhere to obligations of accountability or obligations of explainability. We can think about human agency when it comes to AI health research. One could be incentivization. I think we need to incentivize our developers to think about some way of including regulatory and ethical models. Another idea could be on counteraction. Though we haven't used this in our work, but if there are decision support tools, like clinician support systems that could counteract some of these like threats or risk or biases, that, you know, they could actually help. People have talked about the use of counterfactuals, which have been successful in their work. People have talked about the use of bias prediction models, the use of sensitivity checks. And then there are, like, I know there is the human rights algorithmic impact assessment on AI systems, which I think is valuable because it can help provide some impact assessment evaluation, enforcing the right to contest bias, you know, because AI systems could be flawed. And so therefore people should be able to request redress or sort of recertificate, so like some form of rectification, right? So finally, when we're talking about human agency, we must recognize the dynamics between autonomy and agency, you know, the ability for self-governance, self-direction, and the moral independence for people to decide the extent to which they want an AI technology to be in their lives or otherwise, because healthcare is quite a touchy subject. We must recognize the power dynamics required for vulnerable groups and vulnerable peoples, which in our work we're very, very particular about.